I'd like to invite now Fraser Symmans from MD Anderson. Fraser heads the breast pathology and cytopathology group at MD Anderson, and here he is.
So I'm Fraser Symmans. I'm a pathologist. I direct research operations, and I wear a new hat as well, in that within the clinical trial cooperative group structure, I lead the translational research program for the Alliance. So the interest in the future application of technologies such as this to clinical trial biospecimens with low amounts of archival material is of great interest to the clinical audience, some of whom I'm sure are represented here. What I'm going to show you is a very recent pilot study, which we were invited. Our group works in RNA gene expression, principally working on development of predictors for outcomes in breast cancer. And the model that we chose for our pilot analysis is just to see the feasibility from a research perspective of this technology to archival DNA, which has been preserved after RNA extraction for our studies, which we've historically done and currently do with gene expression arrays. Secondary to that is can we think ahead to a future where we are looking at more of a clinical trial tool where we can get into better precision and a higher signal-to-noise ratio for our signatures. And thirdly, is there potential to be able to translate this to the formalin-fixed paraffin-embedded environment, again in the clinical trial archival setting and also in the standard routine pathology diagnostic setting. So the model we're going to talk about is triple-negative breast cancer. Just very briefly, this is the type of breast cancer that has neither of the hormone receptors and lacks HER2 overexpression. Consequently, it is the least differentiated form of breast cancer and the most clinically aggressive form at a biological level. Its natural history is somewhat more aggressive than the other forms of breast cancer, characterized by early risk of relapse. However, just to add a little complexity and interest to this story, it's also potentially the most curable form of breast cancer by chemotherapy. And what I'm showing here is a system that we developed that's freely available and widely used now called residual cancer burden. And this is a way for pathologists to quantify how much cancer is left after the chemotherapy is being given and the patient then moves on to have her surgery. In pathologic complete response, PCR, different context, same acronym, is the black curve. This is complete remission in the lymph nodes and in the breast. Residual cancer burden 1 in purple is a minimal amount of residual disease, and moderate is 2, and that's red, and extensive residual cancer burden is the blue curve. And you can appreciate that the black and purple curves constitute half of the patients. So essentially, for all intents and purposes, nearly half of the patients with triple-negative breast cancer are actually cured by standard chemotherapy. And for the other half, the red and blue curves, you can see there's significant residual risk despite all of the best current available treatment. And so this sets up a really important scenario for predictive diagnostics. And we've taken this on from the multi-gene array-based platform, training on endpoints such as this, and trying to piece together the various components of prediction and resistance that could lead to an understanding of residual risk after the current planned therapy, and potentially in the future lead to decision making about whether or not to participate in a clinical trial from the outset of new therapies, and potentially even give you some insights as to what sorts of therapies you might want to take on if you are considered to be still at residual risk. These decisions can be made in a predictive medicine scenario from the beginning before treatment begins. So the 3 levels we have used in this model were a proof of concept study, where a predicted sensitivity index to endocrine therapy, which is really not relevant to triple-negative breast cancer because they're pretty much all predicted to be insensitive since they lack the receptors. But then at the levels of chemotherapy, training on response and training on early relapse to develop empirically multi-gene predictors of expression related to resistance. And then at the third level, training on levels of exquisite sensitivity to chemotherapy where it's either completely removed by the treatment or there's only minimal residual disease. And when we published on an independent validation cohort, on the right are the triple-negative breast cancers. 80% of them achieved a pathologic complete response, and their survival curves are shown on the right, wherein those who were predicted to be treatment sensitive by the multi-gene index, that's the red curve, had a markedly better survival than those who were predicted to be treatment insensitive. And notably, the black curve, the predicted treatment insensitive, had a very high rate of early relapse after current chemotherapy. And so therefore, this sets up the potential for clinical utility. So with that in mind, we take some of these samples where we've been working on RNA over the years, patient by patient, and a postdoctoral scientist in my lab, Rosanna Lau, who's in the audience here, found some of these samples, extracted the DNA from the flow-through after the RNA had been extracted years ago, and then we kept the flow-through that had not bound to the silica membrane and just kept it in the -80 for years and years and years. And she dug around and found 8 triple-negative breast cancers that had either done very well or very poorly, and then extracted secondarily the DNA. We sent 500 nanograms quite some time ago to our friends and colleagues at Yale University, Lajos Pustai and his group. And then just a few weeks ago, actually less than a month ago, we sent 50 nanograms to be evaluated with the ThunderBolts cancer panel from the same 8 tumors. So we haven't had time to make the comparisons yet, but I just wanted to present the breakdown data of what we found in the first 8 samples of this old, poorly preserved, shall we say, in terms of this is not the way you would want to keep your DNA, samples from our old studies. And what we found here at the listed 8 samples here, as you can see, the lowest is 2,000 reads per target, but most of them are in the 5,000 to 7,000 reads per target. And at 30x, all of them hit 30x, and all of the tumors had greater than 98% at 100x, which is pretty good. And you can see that with one exception, the uniformity is excellent from these samples. In terms of the mutations, as you will have gathered already, we don't have the germline comparison here, so we're really just showing the observations from cosmic annotation for some of the putative mutations that were observed in P53, PIK3CA, interestingly for KIT as well. And then this is just a visual to illustrate that indeed, of course, we picked up SNPs, well annotated here in either homozygous or heterozygous in most of the patients, and a couple of well annotated mutations, and 2 that at least at first pass looking at the data were not annotated in the cosmic database. So with this in mind, our future applications, we think, are we have the potential with our clinical trial samples to go back and perform efficiently and with a good degree of penetration DNA mutation testing. We think that's a promising use of residual samples. And we're very interested in the possible ways in which the RNA-seq might meet our needs in terms of being able to get at a high number of reads per target. Can we get our gene signatures to a place where they have tremendous precision and reproducibility above and beyond what we can currently achieve? We think this is a very promising technology in order to achieve this. So with that, I'd just like to close and thank you for your attention.